I'm recording.
Somebody got it. Thank you. So the first case is a 48-year-old woman with rheumatoid arthritis on the Humira, adalimumab, and methotrexate, is planning to leave in 3 weeks for the Philippines to visit her family for 2 months. And she's going to stay with relatives in Manila, but then they will probably travel all over to visit some cousins, other relatives. She is up to date on influenza, pneumococcal polysaccharide 3 years ago, Tdap, childhood polio, and she is immune to measles, mumps, rubella. So which immunizations would you recommend? Would anybody like to chime in on to discuss this case?
Now, I think we're a small group, so
Yeah.
it might be fine if everybody unmutes, because with such a small group, we should be able to do it by voice and not chat.
Right.
The others, I don't know if others are, until we have a larger group, can, I'm going to see, I think we're still a relatively small group.
Right.
So, well, I think I'll point out a couple things here that if I were looking at, if this were in my health assessment form, that might trigger me. First of all, she has rheumatoid arthritis. So right away, I'm going to be wondering, even if she doesn't list any meds, which, as I mentioned, is unfortunately pretty common that people won't fill in the medications, I would ask her, are you taking any medications for your rheumatoid arthritis? And because it's, Lynn, as you know, it's the conditions can give us hints as to what else might be going on with their care. And so we see her meds there, which are important. And she is leaving fairly soon. So we have 3 weeks, which is a decent amount of time, but it's not great. And she's going to be there for 2 months. So she's a longer term traveler, and she's going to travel all over. So as we start to filter everything through her destination plans and her travel plans, certain things are going to need to be considered, risks of the longer term traveler. So that's some of the stuff I would see just in her health history. And then, of course, she has her vaccine records, which is amazing because we don't often see complete vaccine records, but she's relatively young. So, she may have been able to pull those together. And the other thing is that people who are going to be put on these immunosuppressive medications, sometimes if they have astute and best practicing physicians, they will have checked also vaccine records, titers, and try to boost things before people go on these meds. So you might have better records. So I'm going to stop talking and maybe let somebody else say something.
Right. So see, none of these choices are perfect for what I would probably do. D may be the closest, but I don't think I would offer meningococcal to this individual. JAP-B would be reasonable, but it's a live viral vaccine, and it's going to depend on when she got her antibodies and in terms of her rheumatoid arthritis antibodies, where she is on therapy and the like, although she does have some risk. So that's my comment, and I would probably take a look up for JAP-B with those antibodies relative to the timing of when she got them.
Okay, so let's think about this. I think in this particular case, I would say congratulations to the primary care doctor who had checked the measles, mumps, rubella titers, right? Because this person probably doesn't have childhood records, but in this particular situation, somebody was astute enough to check her MMR status because she is on monoclonal antibody immunosuppressives, where she should not be getting live vaccines, right? So, Louis, I agree with you that this is we want to avoid any live vaccine in this particular person. So, and then she's up to date on Tdap, polio, so we don't need to worry about those. Then we need to think about the epidemiology and what are her risks when she travels. And the hepatitis A used to be considered one of the most commonly encountered travel diseases, travel-related diseases. So hepatitis A will be one of the vaccines that we want to make sure she has or is protected against hepatitis A. And then now, Japanese encephalitis vaccine is actually inactivated. It is a viral cell inactivated vaccine, so that in theory could be safe for somebody like this. And rabies is inactivated vaccine, so that in theory it should be safe for somebody that's immunocompromised. The other question is, what will their vaccine response be? So from a lot of studies and from COVID vaccines studies, for example, we know that immunocompromised people do not develop a strong response as the average person. So then, so those are the travel vaccines that I started to think about. Then what about typhoid? So you see in A, B, and D, typhoid intramuscular. That is a polysaccharide vaccine, so it's not live. C has the oral typhoid, and David Freeman talked about the oral typhoid if you were able to attend his talk, and that's a live attenuated vaccine. So given the immune compromise, we tend to stay away, we try to avoid all live vaccines. So the oral typhoid would not be a choice. And so that kind of excludes C. And then think about pneumococcal conjugate is in a number of these sets of vaccines. And this is an immunocompromised traveler. So she had pneumococcal polysaccharide before. So the current recommendation from ACIP is to make sure they also have the pneumococcal conjugate vaccine. So you can sort of think about it that way. And then so hepatitis A, we want her to have that. Japanese encephalitis and rabies, we want to think about those. What are her risks? So the data on travelers who are visiting relatives and friends, VFR, visiting friends and relatives, there is associated risk with Japanese encephalitis, diseases such as Japanese encephalitis, and these are mostly in case reports in the US. So, and I think David Freeman also mentioned the number of cases over some decades that are confirmed Japanese encephalitis. It's very low, but if it does happen, it's quite dramatic and has severe consequences, long-term sequelae. So, and then in recent years, a number of the cases in the US that were reported have been children to the Philippines to visit relatives and friends. Another person went to Southeast Asia. So we do keep that in mind. And also the length of stay, remember that that's one of the situations that we consider for Japanese encephalitis. The longer stay, if you're going to be out and about, and in this particular case, she's going to be traveling around, not just Manila, but all over for a couple months and visiting relatives. So these are some of the criteria that leads us to think more strongly about Japanese encephalitis vaccine. Then rabies, what about rabies? Also the longer stay. So if anybody else would like to talk about rabies vaccination or think about how you would address the rabies issue.
Give her an accelerated series for both, but probably.
And I'll throw a wrinkle in there. You know, one of the things is that some of these vaccines can get very expensive and they're not covered by insurance mostly. So it's possible that her Hep A, her pneumococcal, maybe her typhoid, even mid-level insurance might cover that, but often if it's just for travel, typhoid, Japanese encephalitis, rabies may not be covered. So, that we sometimes struggle with this when people might have a fair amount of possible risk to a disease, and they may not either have the time or the resources to become vaccinated. So it's helpful to look also at other ways that she can protect herself from things like Japanese encephalitis and rabies. And we might ask her a little bit more, because she's visiting family, what kind of accommodations will she have when she's over there? How much time does she plan to spend in rural areas? 2 months is a fairly long time, but some travelers know that they have so-and-so's wedding, and then they're doing this and that, and I'm going to be helping my cousin with this or that. They may be able to kind of map out where they're going to be and what they're going to do, especially on a family visit. So we might be able to get a better understanding of how much risk she might have for Japanese encephalitis if she's going to go stay with her uncle on his, farm for, 6 weeks. We might, really kind of stress and say, this isn't covered, but it might be a really important investment for you to consider. Versus if she's going to be more in urban centers, staying in air-conditioned accommodations, we might want to put the emphasis on insect repellents and help her understand how you get Japanese encephalitis, where you get it, and give her other things that she can do to prevent getting exposed, remembering that it is a fairly low risk disease for travelers to begin with. So this is just some of, again, in my talk, how I mentioned we have to really consider who this traveler is and what they bring to the table. And that can help with some of these discussions. Similar
Right.
for rabies as well. And the one thing different with rabies that I like to keep in mind is that rabies exposure, unless there's some, bat, which is, an issue that people can wake up with a bat in their room or something. But for the most part, in a place like the Philippines, it's going to be dog related bites and, exposures. Same thing for cats. So there's a lot we can do in counseling and creating awareness for rabies that can be life-saving for people, even if they don't take the vaccine. I call it sort of awareness, avoidance, and action, sort of the 3 A's of rabies prevention, that they should all be aware of it, try to avoid dogs, petting them, approaching them, marketplaces, don't aggravate them, all the different behaviors that humans do that put us at higher risk. And then quick action if they are exposed, clean out the wound, seek care, stress getting rabies vaccine, rabies immune globulin. So if every traveler hears that, then at least they're off to a better start. And then you can add on the rabies vaccine if they have time and resources and high risk.
Yeah, to that end, that we've had lots of discussions about this with patients when they're going. A lot of people are going to places where there is reasonable health care and none of their relatives have had rabies vaccine. Living in the environment for years, it's not like that's a universal vaccine for everybody. So I was wondering how you approach that. For people going to more rural environments, when we have our medical residents traveling to Uganda, for example, where rabies immune globulin and rabies vaccine, while available, may be much more difficult to get. Those individuals, and many of those stay for 6 months, we routinely give the rabies vaccine. But this individual is kind of on the edge, and they're really going to family in the Philippines. If they're going to stay in the cities in particular, if they have access to healthcare and things like that. While it is a risk, rabies is epizootic in the United States. You could say, how come travelers to the U.S. are not getting it? We certainly have an awful lot of bats with rabies, cats, and sorts of other little cases pop up compared to other countries.
Really good points. And I think I agree with Rebecca and with Luke completely. And I think a lot of these vaccines for travel, it's a shared decision making, right? There is no real cookie cutter that fits everybody. And the itineraries are different, the behaviors may be different. Even if somebody's going to the Philippines, as Rebecca pointed out, they can have a lot of exposures or very little exposures, depending on their activities, where their accommodations, the specific plans. And so here, I think I was just trying to point out that these are the vaccines that we would consider, but will the traveler be able to take them all? It's not clear. And then also the other conversation is, we don't know in the immunocompromised travelers what their level of protection will be. So that comes into the discussion for them to consider whether it's cost effective for them to spend money, and then how to prioritize. And so the preventive measures will be really, really important. The repellent, the going indoors after dark, but certainly in the Philippines, there are day-biting mosquitoes that would also carry dengue and chikungunya and Zika. So that mosquito repellents or vector prevention is going to be really important. For rabies, we heard about how the ACIP just recommended that we could do the 2 doses before travel, but I don't think we have enough data on immunocompromised travelers to safely say, yes, you can do the 2 doses and that you would have the same level of boostability. So I think with the immunocompromised travelers, I would be more cautious to that respect. And for a lot of travelers, rabies vaccine, as Rebecca and Lou pointed out, it may not be, some of these vaccines may not be covered by insurance, so they could be really expensive. So when there's an added unknown about appropriate immune response, and for rabies, I would feel more confident giving them 3 full doses, as the previous recommendation stated. And so it's a complex situation, and it needs to be individually based discussion.
So 2 other things that I've encountered now that people are traveling is making sure that their COVID vaccines are complete, which isn't on here. And this certainly an individual who should have had 3 vaccines, but at the very least 2 before leaving. And the other thing about the rabies is I'm curious how you feel about the accelerated series of 0, 3, and 7 days, which is published, and there's data and suggests that gives a good immune response.
Right. There are some European colleagues that did they're relatively small studies in the accelerated schedule. And so in the immunocompromised, I would favor staying with the longer, the more traditional, better studied schedules, the 0, 7, 21 to 28 days. And for if somebody is severely immunocompromised, and this is in the CDC Yellow Book, immunocompromised traveler chapter that Camille Cotton and David Friedman co-authored, that if somebody is really severely immune compromised, let's say on chemotherapy, and even if they got the rabies pre-exposure prophylaxis series, if they encounter an animal bite, let's say a dog bite in the Philippines, you would still want to think about giving them the rabies immune globulin plus the full series of post-exposure vaccine, day 0, 3, 7, 14, 28. Now, there is very little data on this, but so a lot of it is really extrapolated from various studies and thinking about the lower immune response that are developed in people who are immunocompromised. So, okay, so should we go on to, so probably the standard vaccines that we would all want to do is pneumococcal conjugate for the immunocompromised person per ACIP recommendation. Probably typhoid, intramuscular, not the oral, because the intramuscular is polysaccharide, not live. whereas oral typhoid is live. So then, what about immunoglobulin versus hepatitis A? What are people's thoughts about that?
I haven't used immunoglobulin for a very long time.
Okay, so you would tend to
in
do,
travelers in general, with very rare exceptions. I mean, Hep A, a single shot, gives quite reasonable immunity, even 2 or 3 days after travel. If the people are traveling in 2 or 3 days, they don't, I think most of the data suggests they don't get symptomatic Hep A. And I'm not aware of a great deal of data in a patient like this who's on these
Okay.
modulators, but I would think they would generate a reasonable immune response to that vaccine.
okay. So I think I put in some slides. So here I may have put B as one that I would consider, but so what vaccines are safe? Non-live vaccines, we talked about that. What vaccines are effective? So influenza, pneumococcal are there, and I'm going to get back to the hepatitis A issue in a little bit, but just on the routine vaccines, for people who are on TNF antagonists, there is some impact on influenza vaccine response. For rheumatoid arthritis patients, for example, the geometric mean titer after influenza vaccination is lower if they are on, TNF inhibitors, but the responder percentage is not affected. So basically people do respond, but it's a little bit lower. And if somebody's on TNF inhibitor versus somebody on methotrexate, people on TNF inhibitor or the combination had lower geometric mean titer, lower response, but it's still sufficient, still adequate. So basically, people on these TNF inhibitors and various immunosuppressives, they should still get their influenza vaccines. There is one interesting study out of Korea a couple of years ago that looked at holding methotrexate for patients who are on methotrexate. So what they did was to hold, they had a group that got their methotrexate weekly. They had a group that held where they gave flu vaccine and then held the methotrexate for 2 weeks. And that group had higher response, which is the methotrexate hold group here. So I'll just mention that very quickly. So that's why there's some thinking about when to give vaccines, whether it's possible to hold somebody's immunosuppressive agent. And so very quickly, it's just that they developed a little bit higher response. And then pneumococcal, I'm going to skip over this. Basically, they did develop response, and certain types of immunosuppressive agents develop higher response than others. So in this particular group of people who were on TNF inhibitors had higher geometric mean titer, meaning the vaccine response was higher compared to people who were on combinations with methotrexate. And you probably remember this table from ACIP. So now hepatitis A, what I wanted to point out is that vaccine response is lower in immunocompromised. And so immunocompetent patients, after 2 doses, they have like 98, 99% serologic response, but immunocompromised is lower. It's about 75% after 2 doses. So then some other studies show that 1 dose of hepatitis A vaccine, often we think that within 1 month, in the average person, they'll have plenty of response, and that's going to be adequate. In immunocompromised travelers, it's actually takes longer to build, and it's lower. So seroprotection at 1 month, it was 10%. And seroprotection at 6 months, it did go up to, with a single dose, it went up to 33%. And then after 2 doses, 1 month after 2 doses, 83% developed protection. And then 7 months later, they essentially maintain reasonable protection. So 1 dose of hepatitis A vaccine actually does not appear to be sufficient to protect somebody leaving within a month. So if you have time, administer 2 doses before travel, or if there's insufficient time, you can give them immune globulin, or you can give them hepatitis A plus immune globulin, depending on, and it depends on the specific scenario. And again, the insurance coverage does come into play there. And this was actually a systematic review with pooled seroconversion rates after 1 single dose of hepatitis A vaccine. So down at the bottom here, these are the healthy controls. And you can see that after 1 single dose, most people, average healthy people, develop strong, robust antibody response. And this is the pooled seroconversion again. But then if you're on TNF inhibitor, it's a bit lower. Conventional immunomodulators, it's lower. But after 2 doses of hepatitis A vaccine, you see that their seroconversion rates moved up. And so the way I've been thinking about it is, if somebody is leaving within 1 month, I would definitely want them to have hepatitis A vaccine. If I can give them immune globulin in addition, that would be great. Some European colleagues have proposed that if you have more than 1 month, that you give them 2 doses or give them double dose at the first setting. So in this patient, you can think about giving them 2 doses of hepatitis A. Now, I have no idea what the insurance coverage would be, but you can talk to them about and offer them these different options and different scenarios. But I would definitely offer them the pneumococcal conjugate, the typhoid intramuscular, would favor Japanese encephalitis and rabies. But again, those are discussions to be had about the actual risk, whether they're going to be to be spending significant amount of time in the rural areas, or whether they feel confident that they can avoid dog bites because the relative may have pet dogs or guard dogs around. What do you think, Rebecca or others? You're muted, Rebecca.
I had a bunch of sirens going by outside, so I muted myself. So there was I want to ask a question, and then I'll add in a little bit more if there's time. Peter asks, COVID vaccine response in methotrexate treated patients also need a 3rd dose. Poor response with rituximab, B cells issue. So anybody want to sort of field that one a little bit? I think this is a very new area, in terms of COVID vaccine and how we manage some of these patients. If anybody has any knowledge of the literature and what we might do about that.
Great comment.
What we're doing is this patient would qualify for quote a third, not a booster dose, because we think it's part of the series for a patient with immune dysregulation. They qualify for a 3rd dose, definitely at 6 months. Many of my
in the US
are using titer to S protein to see if they do develop at least a titer and how high it is. It's certainly not neutralizing titer, but using that. And there have been some patients who don't have a titer who have actually gotten the 2nd series. That's completely off label, but it has been done, and some of those have responded.
And I think it's important to realize that this is in the United States, right? So this may not be a global standard, but and it's also right now for just one of the vaccines in the US, the Pfizer. So all these recommendations are changing quite rapidly in the US. So some of this stuff may be off label, even in our own country, depending on which vaccines people have received. And in other countries, they're, you know, particularly outside of Europe and Israel, I think some of the other countries doing boosters and additional doses, there may not be a lot of guidance on some of these issues.
Right. So I think Lou mentioned the being immunocompromised, that she should have the third dose as part of the primary series. And I agree completely for anybody coming in that came in later. And sorry, I didn't put COVID on that. I assumed this is taken care of. So the current recommendation is whether it's Pfizer or Moderna, they should get the third dose. Just to clarify that. And so anybody that's on immunosuppressive agent like this should get that third dose before anybody travels. And then the other question then is, should this person be traveling while COVID is going on, circulating? And so one of the other, so if I were seeing this person in our clinic, we would pull up the case trends in the Philippines and also think about the vaccination rates. Because if she's going to a country that has very high vaccination rate, then presumably there would be a bit less of COVID circulating. And so you kind of have to balance those. The Philippines, I think the vaccination rate is quite low. And so I think those, again, these change from day to day almost. So we have to have those conversations with the immunocompromised traveler during the COVID times.
And one other comment on COVID, which I sort of alluded to in my presentation, is that it's also what's if cases are on the increase, which, you know, I mean, often happens in places with lower vaccination coverage, including the United States. And if hospitals are becoming overwhelmed with COVID patients, and here's a person who's immunocompromised, maybe at higher risk for severe traveler's diarrhea and other conditions. I mean, we're focusing on vaccines right now, but the immunocompromised traveler has higher risk of many things. So they could become ill from something else, need hospital care, and if they can't get the care for, you know, an acute diarrheal illness because there's no beds and the emergency rooms are full and crowded. So I think to Lynn's point, it's really helpful to understand now what's going on with COVID at the destination. So people can, again, they can anticipate. They may still choose to go, but they should be aware of that.
Thank you. And then even though B is highlighted here, A in theory could also be appropriate. You could say the patient, after discussion, insurance is not covering Japanese encephalitis, but will take precautions with repellent, with staying out of the rural countryside farm areas. And with rabies, she has identified a hospital in Manila, perhaps, where she can go and get rabies immune globulin and rabies vaccines if bitten, as well as the preventive measures of staying away from animals and washing off wounds afterwards. So Hep A, so based on the hepatitis A vaccine response data, A in theory could also be correct by offering this person immune globulin. But I agree with you, we have rarely really rarely given immune globulin in the last decade or so.
Yeah, given the half-life of immune globulin, if you were going to choose A, how much would you give her?
Oh, I would look up the dosing. And usually the standard dose should protect for 2 to 3 months. So, and I can't remember that right off the top of my head, not having used it in like 10 years.
And you got to give it in the butt too. Don't forget, in the gluteal muscle, right? I mean,
right.
It's been a long time.
It's a large,
It's a large volume.
Large volume.
Large volume. Yes.
Any data on Japanese encephalitis vaccine response in immunocompromised patients in general?
No, not in a systematic way, and I don't think I've seen measurement. I think that would be a good study to the point that Ed Ryan mentioned, if there's a question, it's a potential study, right? What about immunocompromised people? What's their response to the Japanese encephalitis vaccine? So good question. No data.
Lynn, I'm sorry, Lynn, I can't, I've lost track of the timing because we shifted everything. Does Anne
Yeah.
or Lynn? No, I just want to make sure we give you time for other discussions. If you, do you have other ones?
Yes.
Okay.
So, okay, medications. So you might want to think about malaria, right? Parts of the Philippines lie in malaria zones. So here's the CDC section on malaria in the Philippines. What would people want to give to this person, and how would you explore whether she is going to have malaria risk? Anybody want to take that?
And there's some more people have joined us, so you're welcome. We're a small group, so we welcome you to unmute yourself if you'd like to comment or ask a question. You're welcome to do that.
Get a travel itinerary, detailed travel itinerary for where she's going to be, which will help with assessing risk. You can bring up there are more detailed maps of malaria distribution in most countries, including the Philippines. And then the last thing would be to just check drug interactions with chemoprophylaxis.
Excellent.
In general, you usually go to a atopic progonal in most patients, even though it's daily, because it's usually very well tolerated with limited side effects. But that would be the three things that we would do.
Right.
And the other thing that in terms of the risk assessment, I mean, you can see right here in just a few lines and filtering it through information that hopefully you know or will learn. There's none in most of the major urban centers. So again, where is she going to be? What is she doing? If she's going to spend most of her nights, and malaria is primarily in evening and nighttime, transmitted by a mosquito that transmits mostly at night in the evening. So she's going to be back in a metropolitan area for most of her evenings and nights, staying in good accommodations with air conditioning. That might, decrease the need for this. She may again go out to see her uncle for 2 weeks in a region where it's more rural. So you can also cover people for just the time in a risk area. You don't need to give them the prophylaxis for the entire trip. And something else to underscore here is the malaria species. It's important. CDC does give us this information. And understanding that P. falciparum can develop much more quickly and is really what we think of as the most severe malaria. I mean, there's definitely Vivax is a problem, but the one that's going to kill people quickly in very broad terms is falciparum. So if you see that somebody is traveling to a place with high levels of falciparum, it's really worth it to be very, very mindful and careful. And if they're going to spend a lot of time in a rural area, spend a lot of time with them, trying to get them to agree, again, shared decision making, that it might be the best course of action to take the malaria medication while they're there, so that they don't become a statistic. And if they completely refuse to take it, and even if they don't, instructing on insect precautions, incredibly important. And again, that recognition, malaria, it's malaria till proven otherwise. Her doctors may not think of that, and urgent care may not think of that. So a traveler who's, coming back from a malaria risk area must know that they have to mention that if they're seeking care. That's just a few other things you can glance at from this blurb here on the CDC.
Right. I agree. And I think Lou Kakulis mentioned in the chat, as activities, type of lodging, exactly. The more details, the more you can discern how much risk they might have. And then I didn't really see in the chat that Peter commented about COVID vaccine response and methotrexate, treat patient also. Absolutely. and need a third dose. Rituximab, they wipe out B cells, so they really get almost no response. So those people, I really would not want them to travel anytime during when there's COVID. And let's see, Peter asks, is JE a big risk in the Philippines? Yes, it's definitely a significant risk. And I think one of the ecologically in Southeast Asia, so Thailand, Cambodia, Laos, Myanmar, the Philippines, Indonesia, a lot of the towns and cities are actually abut the rice paddies and farms. So they are in such close proximity to each other. That's why even if somebody said they're going to be in Manila, but they're going to go to some suburbs to visit relatives, we still got to think about Japanese encephalitis. So I think, how much time do we have?
I think you have about 5 more
5
minutes.
minutes. Okay. This is another, okay, so we'll focus on immunocompromised. This is a 34-year-old male, may need to go to Ghana for work for 3 weeks, has ulcerative colitis, on prednisone, azathioprine, so on. He's had chickenpox, had malaria, age 14, way back, vaccine history, has had yellow fever vaccine in the past, probably, has had Hep A, Hep B, although Hep A only 1 dose, MMR is fine, polio is fine, TD is more than 10 years ago. Okay, so what are you gonna give him? I see some errors already about the tetanus diphtheria. So would anybody like to comment on this patient?
Again, you can unmute yourself if you'd like, or write questions in the chat or comments.
Right. Oop. I was looking in the chat, and Lou asked, is there any point in vaccinating against vaccinating people on rituximab? Hard to say. Better doing it rather than not, right? Just like for COVID. But we really think they don't respond well. So we have a vote for B from Karen, I think. And I think, Rebecca, do you want to comment on how you think about it?
Okay, a couple things. I think, you know, at a glance, there's nothing wrong with B. I think I would be careful with yellow fever serology because it has to go to the CDC. It can take a fair amount of time. There's no sort of stat test on that. So they could be well gone on their trip before you get results on that, from what I understand. We don't do this very often. Also, verbal history of yellow fever, unless there's a document in the yellow card that they have, I would not be chasing that down, because yellow fever vaccination is not always mandatory in parts of Africa. There's, you know, different waves of outbreaks depending on the person's age. So, you know, they may have had it as a very young child, and we know from data that that sometimes does not lead to long-term protection. So I would sort of just put all that aside, and, you know, we definitely need to address yellow fever, but hopefully everyone can see right away that we have possibly some issues with giving him, you know, yellow fever vaccine. So then you may want to look at really what he's going to be doing, where he's going to be going, to balance out his actual risk of yellow fever to a waiver. Because remember, a waiver is going to get him in the country, but it's not going to protect him once he's there. So these are some of the things that you'll have to work through.
Perfect. And so I would start thinking about hepatitis A, because he had 1 dose earlier, and now if you give him a 2nd dose, from some of the data I showed a little earlier, after 2 doses, people do seem to develop reasonable protection not as good as the healthy individual, but it's certainly reasonable. And then the typhoid, because he's on immunosuppressive agents, right? We don't want to give the oral typhoid again. And so we would go for the typhoid injection, which is polysaccharide vaccine. And then if he's immunocompromised, we cannot give him yellow fever vaccine, right? So if we want to assess whether he is immune or protected from the potential possible yellow fever vaccine in the past, then a serology is reasonable to do. Like Rebecca mentioned, it takes weeks and weeks. I want to say 6 to 8 normally. And so it may not be practical, but if this is somebody planning for a trip sometime down the line, it may be reasonable to do that. And then this person might have to show proof of yellow fever vaccination. So if you have a serology, you can use that as proof that he's immune. If you don't do it, then I think he still needs a yellow fever waiver, but then the vector precaution, the mosquito precaution would really be critical. Okay.
And somebody did ask that question about would the serology, allow them to get into Ghana? And I think you would have to craft a letter built into a waiver
Exactly.
mentioning this and then attaching the serology, because you have to make it very clear for that kind of immigration entry purpose.
Exactly. So the yellow waiver letter would need to say he's there's contraindication to giving him yellow fever vaccine. However, and then you can add on that his yellow fever serology shows that he has immunity. So live vaccines, the live attenuated intranasal, we want to avoid MMR. So this is just a note about the live vaccines that are available out there that we want to avoid. BCG, we really rarely ever use in the US for prevention of TB, but
Sorry,
it is used
I couldn't
elsewhere.
hear what you said.
Oops. My Siri talking to me. Sorry. And then some contraindications and precautions. So pointing out this section on the left are the contraindications and the section on the right are precautions. Over the years, people have asked about somebody 65, should they even be considered for yellow fever vaccination? And it's really just a precaution. It's not an absolute contraindication. And so it depends on their itinerary, right? These underlined parts were added around 2010 when we realized, when we recognized the rare but severe adverse events, viscerotropic and neurologic, that are associated with yellow fever vaccine. So thymus disorder, and that includes myasthenia gravis, or people with a history of thymoma where the thymus has been removed. That's a particular background of concern. And then anyone on immunosuppressive and immunomodulatory therapies, that's a contraindication. The other ones were already, contraindications already were in existence. And then for precautions, the added precaution was this age 60 or older in 2010.
Lynn, I'm sorry, I think we may need to do a time check.
Yes.
For the next session. I believe if we might go right into the next session now.
We are? Okay.
I think is Anne Marie still there? The timing shifted, I believe, by 15 minutes. So it looks like the next session is starting now at 11:45. Is that Anne Marie, are you there? Because I don't have an updated agenda. The one I have is, so does anybody, can anybody, because I just want, if people have to move on to another session, and I don't know, Lynn, if you're meant to be somewhere else. I'm needed to moderate on another session that starts after this one.
Okay.
Although it may not be as fun, Lynn, without you. It's always fun to work with you. Although Gerard will
course.
also be, I look forward to moderating his session too.
It's so fun to work with you, Rebecca. So for all those others who may not be in ISTM yet, you can tell that we made a lot of friends through the organization from various collaborations, and sometimes just shooting each other an email or message. But how would you manage this patient? How would you deal with this? Is there that much yellow fever there? Has there been significant Japanese encephalitis in this particular area? To Peter's question recently. So
I don't know if we've heard from Anne Marie, but
I just looked up, and yes, the new session.
it's the new sessions are starting now.
Yeah, so you can,
Just thank you, everyone, and thanks very much to Dr. Lin Chen for this. And I hope everyone will go on and learn and participate some more today. Thank you.
thank you, Rebecca. Thanks, everyone. I think if anybody's coming on, I might just start with